Good evening, all. On behalf of Dr. Agarwal's Institute of Optometry, I thank you all for joining once again for the episode 4 of Optometry series. I would like to thank all our subscribers and viewers for giving us immense support for the last 3 episodes. With the success of the same, here we are today with the 4th episode. The topic for today's episode is OCT and its interpretation. I would like to welcome our HOD of Innovation and Research, Maheshwari ma'am, to talk about the topic and about today's moderator. Hi, ma'am.
Hello. So thank you, Gomadi, for this introduction, and very nice to meet all of you and our expert today for the topic OCT and its interpretation. So Ms. Maanasi. So we have been seeing her work, in the last few years. She's been working continuously on OCT, and we have seen her recent publication in OCT. So we are so proud to have her here, and just I heard that she's seeing more than 100 cases per day in just OCT, and she's personally seeing the patients, and she sees that she has a lot of experience in interpreting the OCT, and she gets interesting cases, and she takes her own effort to publish it. So we are very proud to have you here, Maanasi. Thank you for accepting to join us as moderator. And I'll also like to thank our student who's going to present, and welcome our senior faculty, Ms. Hema. So I would hand over this to Harshini to introduce it formally.
Thank you, ma'am. Good evening to one and all present here. It's my pleasure to welcome you all to our 4th optometry series. The topic for today is OCT and interpretation. It's a great honor to welcome today's moderator, Ms. Maanasi Mahalingam. Ms. Maanasi Mahalingam is an optometrist from India. She completed her bachelor's in optometry and master's in optometry at Allied School of Optometry. Currently, she is working as a clinical optometrist and optometry faculty at Arvind Eye Care System, Chennai. She recently completed her prestigious fellowship in American Academy of Optometry, FAAO, in 2020. Her areas of interest are posterior segment diseases and diagnostics, such as OCT and OCTA, low vision and image analysis. She has also published some of her works in national journals. Now, I would like to request today's speaker, Ms. Hema Sruthi S., to start her presentation. Thank you.
Hello everyone. Now let's start with the topic OCT and its interpretation. Introduction. Optical coherence tomography is a powerful, non-invasive imaging modality that performs high-resolution, microscale, cross-sectional imaging of the retina. It is an optical analog of ultrasound imaging that uses low-coherence interferometry to produce cross-sectional images of the retina. It captures optical scattering from the tissues to decode spatial details of the tissue microstructures. OCT uses infrared light from a superluminescent diode that is divided into 2 parts, one of which is reflected from a reference mirror and the other is scattered from the biological tissue. The 2 reflected beams of light are made to produce the interference pattern. The echo time delay and the amplitude of information makes up the A-scan. A-scans that are captured at adjacent retinal locations by transverse scanning are combined to produce a 2-dimensional image. Generations of OCT. The first concept of seeing the inside tissue started in the year 1971, and by the year 1996, the first commercial ophthalmic OCT device came into play. In the year 2002, there came the time domain OCT, and by the year 2006, there came an upgradation to the spectral domain OCT. Then, by the year 2012, the commercial swept source OCT came into use. And now, the latest advancement in OCT, OCTA, was launched in the year 2014. The aim of OCT was to observe and examine the layers of the retina. The first image here is the report from the time domain OCT, and the second image is the report from the spectral domain OCT, and then the enhancement of spectral domain OCT is shown, and then the swept source OCT is given. This is an image from the swept source OCT, Spectralis. This even gives the smallest detail about the blood vessels in the retina.
Okay, let's get into the interactive session of the part. Sorry, interactive part of the session. That is getting into quiz number 1. Please list down the 10 layers of retina from the posterior to anterior part of the eye.
Meenakshi, there's someone who's making some noise. Sajna Bia, who's the host? Can you ask them to mute that person? Yes, thank you.
Yes, ma'am, muted, ma'am.
Yeah, thank you.
Yeah, Shruti, continue.
Principle of OCT. In time domain OCT, the broadband source is split up into two, and the one reaches the reference arm and the other to the sample arm. And both are again brought back to the splitter, and then it reaches the detector and a scan is produced. In spectral domain OCT, instead of a detector, a spectrometer is used, which produces a time echo delay, and then a scan is produced. In spectrometer-based OCT, a broadband light source is used, and a swept source-based OCT uses a sweeping light source, and the images are captured with the help of a photodetector. This is a comparison of time domain, spectral domain, and swept source OCT. In time domain, the image acquisition is done with the help of superluminescent diode, single photon detector, and a moving mirror. And the scanning speed is 400 A scans per second. It images from vitreoretinal interface to RPE. In spectral domain, broadband superluminescent diode source, array of detectors, and a fixed mirror is used. The scanning speed is 27,000 to 70,000 A scans per second. It ranges from posterior cortical vitreous to sclera using an enhanced depth imaging. Swept source image acquisition is done with the help of swept source tunable laser and a single detector. The scanning speed is 1 lakh to 4 lakh A scans per second, and the range of imaging is from the posterior cortical vitreous to the sclera. Protocols used in OCT. Mostly, a common line scanning, radial scan, and scatter plots are available to scan the retinal layers as such. We have specified protocols to scan optic disc, macular scan, glaucomatous functions, thickness map, segmentation map, extended view towards the choroid. Advanced OCT gives motion-free image using an eye trackers. The first image shows the scan of a macula using a cube, and then the second one shows a radial scan, and the third one is an asterisk scan. And on the right side, you can see a thickness map for with quantitative analysis. And the next one, you can see the scanning of the optic disc is given. Color reflectivity. Highly reflective layers are RPE, photoreceptors, and ILM. Moderate reflective layers are plexiform layer and ALM, and low reflective is nuclear layer. Abnormal reflectivity indicates high reflectivity, pigment accumulation, hypertrophy of retinal pigment epithelium, nevus, scar, neovascularization, hard exudate, and low reflectivity are seen in retinal edema, cystoid edema, cyst, PED, and SRD.
Getting into question number 2. So as Shruti taught us, we have 3 kinds of reflectivity in OCT. So RPE layer and photoreceptor layer exhibits that kind of reflectivity. Participants, do answer in the chat box, be it Zoom or YouTube, do answer in the chat box. Continue, Shruti.
Clinical application of OCT. Optical coherence tomography provides both qualitative and quantitative analysis of the examined tissue in situ. Qualitative data can be in the form of identification of retinal pathologies like vitreomacular traction, macular holes, cystoid macular edema, choroidal neovascular membrane. Quantitative data such as foveal thickness are used to make treatment decisions like in conditions such as ARMD, diabetic macular edema, and retinal vein occlusions. Clinical application of OCT includes clinical aid in diagnosis and prognostications to plan treatment, monitor response to treatment. This image shows the 10 layers of the retina. Interpretation, morphological identification, deformation of retina seen as concavity and convexity, deformation of retinal profile, disappearance of foveal depression, epiretinal membrane, macular pseudoholes and lamellar holes, macular hole. Intra-retinal structure changes such as cysts, cottonelle spots, hard exudates are seen. Posterior morphological changes such as RPE detachment, serous retinal detachment, drusen, choroidal neovascular membrane is seen. The current nomenclature of OCT is showing 18 layers of the retina. Apart from our 10 normal layers, we also have myoid zone, ellipsoid zone, Sattler's layer, Haller's layer, Henle's fibrous layer. We can see in Haller's layer, we can see the outer choroidal layers containing the larger choroid vessels. In Sattler's layer, the vessels are medium sized.
Quiz number 3. From the previous slide, try to answer what is the outer choroidal layer containing larger choroidal blood vessels called as. Continue, Sruthi.
Regions. The OCT image of the retina can be subdivided vertically into 4 regions: pre-retina, epiretina, intra-retina, and subretina. Pre-retina. Pre-retina will read about the vitreous. In pre-retina, the vitreous is examined. In the first image, you can see an necrotizing retinitis, and the hyperreflective dots that are seen in the hyporeflective vitreous are the inflammatory cells. And the second image shows proliferative diabetic retinopathy, and the pre-retinal vitreous hemorrhage is seen. And the hyperreflective dots in the third image clinically denotes the asteroid hyalosis. Epiretina. Epiretina, in this image, you can see posterior vitreous detachments. In this image, the first image, you can see complete PVD. You can see it's floating in the vitreous cavity. And the second image shows vitreomacular adhesion, in which we can appreciate perifoveal separation and an intact foveal contour. In the third image, you can see the posterior cortical vitreous is detached from the optic disc and an incomplete PVD is seen there. Vitreomacular interface. Vitreomacular interface disorder is similar to vitreomacular adhesion, but the foveal contour is disturbed and distortion of the retinal layers is seen in this image. ERM. In this, epiretinal membrane is formed. Epiretinal membrane formation happens when the posterior cortical vitreous detaches from the retinal surface and vitreoschisis happens, and some part of the posterior cortical vitreous is attached to the surface of the retina, which undergoes proliferation and an ERM is formed. This is shown as an hyperreflective membrane in the OCT. Stages of macular hole. In the first image, you can appreciate that vitreomacular traction is seen and the cyst is formed, the inner layer of the retina. In the second image, you can see one edge of the hole is attached to the posterior cortical vitreous. And in the third image, you can appreciate the posterior cortical vitreous is completely detached from the macular hole. And in the fourth image, you can appreciate that the posterior cortical vitreous is also detached from the optic disc. Intra-retinal disorders. In the first image, it's cotton wool spots are seen. These are seen as thickening in the nerve fiber layer. In the second image, you can see hard exudate. These are seen as hyperreflective dots in the plexiform layer of the retina. In the third image, you can appreciate microaneurysms. These are outpouchings in the nuclear rail of the retina. In the fourth image, you can see drusens that are seen in the RPE layer. The next one is CME. In this cystoid macular edema, you can see edema in the macular region, and there are cystic spaces seen in this image. Retinal telangiectasia. These are hyporeflective spaces seen due to loss of tissue. The ellipsoid zone, the ELM, the outer nuclear layer, and the photoreceptor layers are mostly lost. Subretinal disorders. Hyperreflectivity. In this, we can see vitelliform deposits is the best example for hyperreflective subretinal disorder. In this, the hyperreflective materials are seen in this image, vitelliform deposit. You can appreciate the hyperreflective layers in that. Then, in the second image, you can see this happens due to inflammatory reaction, and inflammatory cells are seen as hyperreflective cells. And in the next one, you can see hyperreflective membrane is seen, which happens in ARMD. Choroidal neovascular membrane is a major condition happens in ARMD. Subretinal disorders, hyporeflectivity. These are hyporeflective spaces seen in between the neurosensory retina and the RPE-Brooks complex. In the second image, you can appreciate hyporeflective subretinal fluid that is filled due to fractional retinal detachment. Types of PED. The first image is drusenioid PED, and the second one is fibrovascular PED, and the third you can see serous PED, and in the fourth one you can appreciate hemorrhagic PED. ARMD. In the first picture, you can see disruption of the RPE layer is seen along with the drusen deposits consisting of drusenioid PED, and the second image you can see thinning along with hyporeflective substance there. And third one, neovascular ARMD, is seen with cystic spaces and neovascular membrane. Choroidal tumors. Lumpy protrusions of RPE and Brooks complex are seen. In the first image, in choroidal hemangioma, choriocapillaries are preserved, but in the second image, in choroidal melanoma, the choriocapillaries are lost, distortion and compression of the choroidal vessels are also seen there. And this is a thickness map of OCT showing a different thickness of the retina in a circular map. And this is the image of optic disc drusen, and you can see the optic disc is fraction and its image of the optic disc drusen.
Getting into question number 4, from the previous interpretations, try to find out what is the pre-retinal region interpretations or findings, and list down any few findings from that. Okay, Shruti, continue.
Now let's move on to optic nerve head. In this glaucomatous finding, this is an advanced glaucoma report. Here you can see that thinning of the RNFL in the optic nerve head is quantitatively shown. In the graph-like diagram, the reference marking will be in the green line if it is a normal report, and if it is an abnormal report, you can see the reference marking in the red color, that red color line. Then red color is denoted for abnormal findings and green color for the normal findings. Now, next move on to OCT Angiography. OCTA is one of the breakthroughs in the advancing field of ophthalmic imaging. It is a very useful clinical tool to evaluate structural vascular anatomy of retina, choroid, and the optic nerve head. The principle of OCTA is based on low coherence interferometry principle. Sequential B scans are taken over time position at the same retinal location and subjected to analyze for change in amplitude or phase of image captured by device. The reflected beams are detected as high flow, slow flow, or no flow zones. Movement is suspected in case of any change detected in intensity, amplitude, phase, or both. The movement is due to the flow of erythrocytes in the vessel. Interpretation of OCTA. Here, the red color denotes the NFL and it's interpreted as the superficial retinal layer. And the next, you can see the green color line and it's denote IPL and it's interpreted as deep retinal layer. In between the OPL and the RPE is the avascular zone, and it is interpreted as avascular retinal layer. And the yellow color you can see, that is the choroidal zone, and it is interpreted as retinal depth encoded.
Okay, the last quiz of the session. OCTA works by detecting the flow of dash in the blood vessels. Continue, Sruthi.
Abnormality seen in OCTA. Abnormal flow denotes neovascularization. Abnormal or anomalous vasculature denotes aneurysm or dilated vessels. No flow or dropout areas are seen in non-perfusion. Clinical applications of OCTA. Diabetic retinopathy. FOV is indicated for vascular changes in DR. OCTA detects early changes in DR with vascular losses. Commonly noted changes are vas enlargement with DR progression, microaneurysms, and capillary dropouts. ARMD, retinal vascular occlusions, retinal pathologies like macular telangiectasia, retinal inflammatory disease, retinal tumors, and retinal hereditary dystrophies. And these are the reference for the PPT. Thank you.
Thank you so much, Shruti. Now request Maanasi ma'am to share some clinical pearls.
Is my voice audible?
Yes, ma'am, you're completely
Okay.
audible, ma'am. We are
Thank
very
you.
happy to have you here, ma'am.
Thank
The
you.
man of the match in taking OCT pictures. It is century every time.
Thank you so much, ma'am. Thank you. I would like to see Miss Hema. You did really a very, I mean, to be frank, a wonderful presentation on OCT. The content, and even the way you spoke about the content was very clear, and it was very crisp also, and not very elaborative and extensive. So I usually give so much corrections in the PPT itself when I was given a chance to moderate my juniors when I was in my masters. But in your presentation, I couldn't see like much of the, I couldn't comment even, I couldn't comment much of the things. So it is very clear and crisp. Before, only few suggestions is that, I could see references, but it is always, it would be better to quote the references on that slide itself. And I hope all these, some of the OCT pictures are from your own clinic and some will be from the literature. So it would be better if you could quote the literature, the reference on the same slide itself, so that we can see how reliable the content is. And I have very few questions. You can try to answer. If not, we will discuss. Have you have any idea about the hole forming factor?
Macular filament.
Yeah, hole forming factor. Do you have any idea on that? In macular hole, there is an index called HFF, which is called hole forming factor.
I think the others also can answer, so
Yeah.
that we have a wide range of audience here with us. So I would encourage all the interns, the externs, the master students also to interact, fellowship.
Hema, you can give it a try. I think you know the answer. You can just give it a try. There is no right or wrong here. It is hole forming factor. Okay, you'll read about it and mail it to me, the answer.
Yes, ma'am. Sure.
So it is a prognostic factor. I'll just tell the basic thing, which is, Susie, I asked this question since you spoke a slide about the macular hole. So macular hole, so there is a prognostic factor which is called hole forming factor. So it is like a simple mathematical calculation which will be done using the OCT image of the macular hole, which will tell us whether the patient will have a good closure rate after the surgery. So there is some cutoff value. I'm not going to tell now. So you should find out and mail me. So there is a cutoff value based on which the patient will be it will act as a prognostic factor whether the patient will have a good closure after the surgery or not. Okay, and in slide number 17, you told about there is a deformation in the OCT contour, which is the concavity and convexity. Any idea about it?
In myopic, like high myopic cases, we can see them.
Okay, so in high myopia, have you seen any cases on high myopia, the OCT in high myopia?
Like I haven't done one, but I have. Like,
Okay, have you observed OCT or while doing, you're in your internship, right?
yes, ma'am.
Okay, have you seen OCT while performing or the reports of OCT or
Yes.
only during this presentation?
No, I have.
Okay. Okay, so a general suggestion or general rule for interpreting OCT report as an optometrist is that first you should speak about the foveal contour. So how is it? How is the dip? Whether it is normal or altered or shallow. So can you list any few conditions with altered foveal contour? So usually it's the dip. If you don't find the dip, it is abnormal. So I mean, you can just revise your presentation and see which has an altered foveal contour, and you can list few findings. And even others can try to answer. I'm asking very basic questions.
ARMD.
So, ARMD has altered foveal contour. Is it so? Don't get scared. Get relaxed and then answer. So the foveal contour should be like a dip. When it will be elevated, or when it will not be, there won't be any dip. I'm asking those conditions. Any one or two conditions. You had those in your presentation. When will you have an elevated foveal contour?
In diabetic retinopathy, we can see.
Okay, diabetic retinopathy or diabetic macular edema?
Diabetic macular edema, we can see.
Okay, then what else? What else condition you can see? One common post-operative complications of IOL. It will be similar to DME.
And
Yeah, this can try.
Someone has altered in the chat box.
Okay.
So that is CME.
Yeah, we are getting the answers in YouTube also. Someone has posted vitreomacular tractions.
Maanasi, you are on mute.
Yeah.
Yeah.
So those are the conditions which has altered foveal contour. Okay. So I mean, so we as an optometrist, we are responsible to interpret whatever the report the patient brings to us. So if you just get to see any OCT report, just see how it is, because you have beautifully like the common most finding in the retina is the diabetic retinopathy. So you have beautifully posted how the hard exudate looks like, how the corneal spot looks like. So if you get to see any patients, always try to start about the normal foveal contour seen with these and these. And then also you should end with, there are other two quantifying biomarkers. Which I think you have listed in your presentation, which is the foveal thickness and subfoveal choroidal thickness. So these are the main quantifications which can be done using OCT. So all the OCT machines will have a regular caliber in that, where we can measure this. So can you name some conditions? Even others can answer. I'm asking too many questions to Ms. Hema. Even others can answer. Can you name some conditions where the foveal thickness will be high and the foveal thickness will be low? Any few conditions, any common or rare, any few conditions. When will the foveal thickness will be increased? I think we have discussed just now. And when will the subfoveal, and also about the choroidal thickness, when it will be thinned or when it will be increased? Any idea? Others? Is there any answers from YouTube?
Yes, ma'am. Foveal thickness high, they have said about edemas. Any edemas in retina will cause foveal thickness increase.
Okay. Hema, can you give a try? When will the fovea be thinned?
In some detach, like in loss of tissues, ma'am. Like telangiectasia.
Yeah, perfect. So telangiectasia, the fovea will be thin, where we couldn't see the. Okay. So, and then one more factor is that subfoveal choroidal thickness, which is also a factor which has to be looked upon in the OCT report. I mean, not everyone will mark and send the report to all the patients. So clinically, we should write about the foveal thickness and subfoveal choroidal thickness. So the subfoveal choroidal thickness is mainly useful in cases of ARMD. So choroidal will be thinned or thickened in ARMD? Thinned. So there is another like a spectrum of disease called pachychoroid. So the name itself says pachy means thickened choroid. So there are two. One is the one form of ARMD has thin choroid, and there is another form which is called polypoidal choroidal vasculopathy, which is with the more or less the features will be similar to ARMD, but the main differentiation is that it has a thickened choroid. So for those patients, OCT alone is not enough. We'll be advising the patients to do OCTA or angiograms, FFA and ICGA, which will help us to rule out whether the patient has pachychoroid or the leakage in that, based on which the treatment, the modality will be differing for both ARMD and pachychoroid. So you can read about pachychoroid spectrum. There are so many, central serous chorioretinopathy, you'll be familiar about that. So those conditions comes in the pachychoroid, whereas the ARMD has thin choroid. So we should always see how the foveal thinning, how the thickness of fovea, and also the thickness of choroid as well. Okay, and then you can also give a tentative diagnosis saying that the OCT report tells me this. You can put a query mark saying the patient has DR or NPDR. So it will give a clinical clue to the ophthalmologist also that the patient has already done OCT somewhere else, and they have all come with some OCT report, so that it will be easy for them to come to a diagnosis quickly. Okay. So Hema, do you know the difference between sciatic and cystic spaces? Sciatic and cystic spaces.
Cystic spaces are due to accumulation of fluids.
Okay, that is cystic spaces. And sciatic spaces?
I think it's like detachments.
No, it is not detachment, like more or less a kind of detachment. But cystic means the name itself says it is cystic. It will be in the form of a round, like oval shape. Whereas sciatic spaces will be here like a stretched thing. That is because, as the name suggests, just schisis. So schisis is different from detachment. If the entire retina is pulling away from the RP, it is called, we call it as a detachment. But this is just getting pulled because of traction. So those cases we'll call it as sciatic spaces. So all the DR patients and DME patients will both have cystic spaces and sciatic spaces. Okay, and you beautifully told about the regions of OCT. So those are the main points which has to be covered in OCT interpretation, and you have covered it very well. So as you told, there is another fluid collection also. So when it is within the retina, it is called intra-retinal fluid, IRF. When it is within the RP, it is called subretinal fluid. So IRF and SRF are the biomarkers for biomarkers to tell that the patient has an active disease. So which will help the ophthalmologist to choose whether anti-VEGF has to be given or not. Okay, so and nowadays the whole world is moving towards OCTA. I think OCTA is well studied and well published in all the conditions. But for not every findings can be picked up by OCTA. So for some patients, FFA ICJ is still indicated. We are not in a complete world where the FFA and ICJ is completely not advised. So for some cases, we still advise OCTA, but still if the findings are not clear, we will advise FFA and ICGA. And for OCTA, the patient should not even move their eyes or blink in between, even though there are some process like motion artifacts which can be deleted by some software eye tracking system. Not all the patients can just stare at the OCT machine for 2 to 3 minutes for the whole OCTA to get completed. For those patients, FFA and ICJ can also be done. Okay, and just a suggestion, as a friend, maybe you can also add research papers regarding OCT. Since you're speaking about OCT, any topic, because since you're in your internship stage, once after completing your internship, you'll be next moving on to the other clinical or any research cadre. So it is always better. So this is the time where you can learn from the theoretical as well as research side. So today itself go and then take a research paper, but don't see about the OCT and its interpretation because it is already done. Choose a paper where they have taken OCT as a like a pre and post of after surgery, or as a macular hole, or after a DME patient, how the patient's OCT is changing pre and post the injection. Okay, so just give a try, and then you can. So if any questions, or you can also mail me the answers for the questions which I have asked you. Okay, very good. All the best. Do you have any other questions or doubts? You can ask me.
Yeah, students, if you have any questions, you can ask, or you can post it in the chat box. So in the meantime, Maanasi, so you were discussing like, pre and post results of the OCT. So just as an innovator, I'm just thinking, so there are certain areas where you can measure it, no? It will give you exact values. But cyst kind of thing. So do you have, or is there any attempt that has been done, like, pre and post, we compare it using any software or image processing? Or is there anything that has been done or attempted?
Ma'am, usually, to my knowledge, many of the researchers and the optometrists and ophthalmologists use ImageJ or Fiji,
Okay.
which is an image
Okay.
analyzing software. So
Okay.
even for my master's study, I have worked on that.
Okay.
So we found out a new, choriocapillaries flow deficits. So we
Okay.
took the OCTA images
Okay.
as Hema detailedly
Okay.
mentioned about the segmentations
Okay.
of Octa. We have
Okay.
taken only some images and we have loaded in that image and we did some calculations. And then we found whether it can be a biomarker for a patient for whom the disease is in early stage and for whom it is in advanced. So there is one that factor is that software is very
Okay.
used widely, ma'am, which is called Fiji and ImageJ.
Okay.
And there are few other applications like Angio Tool.
Okay.
So I am aware of only these two, but there are so
Okay.
many. But commonly used is the Fiji.
Okay. Okay, so this ImageJ, I have seen it's freely downloadable, and the other things are they freely downloadable?
Yes, ma'am. Everything is
Okay.
freely downloadable. Yeah.
Okay.
And
So
there is also a forum where we can post our questions and ask our doubts,
Okay.
and there will be some person. I mean, the persons who are interested can reply in that, who
Okay.
know about the imaging. So it
Okay.
is really a very useful image analysis in software, analyzing software.
Yeah, so that's a great one to know.
Yeah.
So, and people are nowadays moving towards this myopia boom, and how often you are seeing this retinal detachment with a high myopia, on is it increasing in your experience, or is there any way to predict this myopic changes in the retina with OCT in the early stages?
Ma'am, usually OCT is not indicated for the early myopes and not for the kids also. But if the child or if the young adult has like more than if the patient is coming for us to a retina opinion, if they complain of any floaters, we will see the concavity of retina. And we will also see a dome-shaped maculopathy. So all these patients will be followed up for every 3 months and 6 months, and we will be just following up the OCT. But retinal detachment is not very common in, but myopic maculopathy is common with choroidal neovascular membrane. But it is very difficult to do the imaging for them because here we use Spectralis. So in Spectralis, the wide field OCT is about 12 millimeters. But even in the 12 millimeters, the disc and the macula cannot be covered for a high myopic patient. And the patient will also find it very difficult to focus just for a minute since they are very high myopic. So there are some difficulties in imaging the eyes of high myopia, but there are myopic maculopathy is common, but not the retinal detachment.
Okay.
Yeah.
So great to know this.
Yes.
Okay. Gomati, you have anything?
Yes, ma'am. Maanasi, ma'am, we got a couple of questions before which we will discuss about the quiz questions today.
Yeah.
So I would like to welcome Ms. Meenakshi to pitch in and to discuss about the quiz questions today. In the meantime, I request the viewers to post any questions if you have any.
Okay, let's see the answers for the quiz asked. Okay, the first question, list down the 10 layers of retina. So from posterior to anterior, that is from the choroidal part to the vitreous part, we have 10 layers. That is RPE layer, photoreceptor layer, external limiting membrane, nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, GCC, RNFL, and your ILM. Second question is RPE and photoreceptor layer. What kind of reflectivity is exhibited? That is, they possess eye reflectivity. We saw in the previous slides, it was in orange to yellow color. That we call it as higher reflectivity in OCT. Then the outer choroidal layer containing larger choroidal blood vessels is actually called as Alus layer. We saw two layers, Atlas and Alus. Satellus is actually the medium-sized choroidal vessels. Alus is actually the larger-sized choroidal vessels. Then few findings in pre-retinal regions that as Sruthi taught us, it is nothing but the vitreous cells, vitreous hemorrhages, and asteroid hyalosis. These can be the few findings that you see in the pre-retinal region, that is in the vitreous cavity. The last question is, Octa works by detecting dash in the blood vessels, that nothing but the erythrocytes. Thank you, Gomati. We can move on to the questions now.
Yes, ma'am. Okay, Maanasi ma'am, we quickly discuss about the first question that is asked in the YouTube, the current classification. So in the slide also, Shruti has added the current classifications. Do we put that into use anywhere, ma'am? The current classification, new nomenclature.
May I know current classification of OCT layers?
Yes,
Yeah, it is the same. It is the same, even which we follow till now. It doesn't change. There are few modifications which are made, especially in the ellipsoid layer. I mean the ISOS junction. So those, I think that is also been included in that. Yeah, slide number 20. That has also been included in this slide, and this is the conventional thing which we use. I couldn't see the slide.
Just a minute, ma'am.
Yeah.
Yeah, that actually they're asking what is the use of having the extra layers. That is the Satellus layer, Alus layer, ellipsoid zone, myoid zone, and all.
The use, see something someone has named this. I don't. So it is always better to label something, no? Instead of telling the defect is there, defect is here. It is better to say the defect is in the Alus layer and Satellus layer. So these are. It is like a
more
rule
specific to the location. No, we can locate it properly.
Yes, ma'am. For that is why we perform OCT as well. Yeah, to tell the defect position and layer by layer, we use this nomenclature. So these, the ellipsoid zone, myoid zone, and these and interdigitization zone, all these zones are very new. I mean, not very new, but they are just added to the nomenclature. And I'll just share my screen. So recently, I couldn't share. Can you please give me the rights to share? Yeah. So recently we have published this OCT feature. So it is called ellipsoid zone complex. So which we found it to be, I mean, there was no literature on ellipsoid zone complex at all. There is a zone called ellipsoid zone, but this patient had, so this patient came to us 3 years back. So initially she was diagnosed to have central serous choroidoretinopathy, as we can see here, but the patient followed up only after 3 years. So after 3 years, without any history of any injections or medicines or nothing, the whole fovea and the retina got resolved by itself on its own. So it is completely a spontaneous resolution. So we have given the legend as well. So you can give it a read. So this ellipsoid zone complex is a new nomenclature. So there are only few papers available, and there is in our literature search we found there are no papers on ellipsoid zone complex. So those were the new nomenclature followed here. Gomati, or mute.
The next question, ma'am. What's the difference between FFA and Octa?
So the main difference is that in FFA we will be using the dye. So we will be injecting the dye, and the dye will be sent from the arm to the eye, and then we will be capturing few images. But not every patient will be compatible with the dye. Many will get anaphylaxis at the worst complication, or even if they get allergic, so allergic to the dye itself, we cannot perform FFA and ICJ for all the patients. So instead, they found using the principle of the erythrocytes flow. Recently, I mean by 2018, as Ms. Hema quoted, Octa has been discovered. So in Octa, for not every patient, the dye injection is really required. So for those patients, we can see, and in Octa, I would also like to add few more points as I'm more interested in OCTA. So in OCTA, the whole retina will be classified into few segmentations. So for all the retinal conditions, we should see about the superficial and deep capillary plexus. For conditions like diabetic retinopathy or branched retinal vein occlusion or any kind of occlusions, we should only focus on the SCP and DCP. But for any conditions which is below the RPE, which is CNVM or ARMD or PCV, we should concentrate on the layers on the segmentations below the RPE, which is the ORCC, which is outer retina to choriocapillaris complex, and choriocapillaris layer, where we will see the hallux and atlas, and then Brooks membrane and all those. So these segmentations has to be observed whether the patient has any abnormal vascularization, based on which we will find the treatment modality will be chosen. So this is the main benefits of OCTA and FFA. And FFA is time consuming, whereas OCTA is not. It is just of 2 minutes. Whereas for FFA, the whole procedure, like the physician has to be give clearance. And if the patient is again a heart patient, they should stop those medications. So there are many more there are many more standard procedure before performing FFA and ICGA, but which is not really required for OCTA.
Actually, the patient will know the world of difference between these two because they need not go through this tedious procedure, right? Yeah.
Okay, ma'am. Next question from YouTube audience. How could we find the difference between CME and DME in OCT?
If the patient, so it is mainly based on clinically. Both have the elevation of foveal contour, but if the patient is post-operative and if the patient has IOL implantation recently, they could give it could be a CME. But if the patients have with the presence of SRF and IRF and any other diabetic retinopathy features, we can call it as a DME. That's the major thing to get differentiated.
Okay, ma'am. One more question from YouTube audience. Can we find the leak point in CSR patients using OCT?
No. So see, if we inject something only, we can see something is leaking out. If you're not injecting something, we couldn't see. So to find out the leakage, we should perform ICG and FFA.
Yeah. One more question from YouTube, ma'am. What's the difference between the hard exudates and drusen in OCT?
Hard exudates is totally intra-retinal, whereas drusen is completely subretinal, drusen will be above the RP layer, whereas the hard exudates will be in the outer plexiform layer, as Ms. Hema told perfectly. And there is some other thing called corneal spots, which will be in the corneal spots. So for at this time only the nomenclature plays a role. So where the defect is, we can tell the name of the condition itself, the name of the finding itself. When it is nerve fiber layer, it is corneal spots. When it is outer plexiform layer, it is hard exudates. When it is below, nearing the RP, it is called drusens.
Okay, yeah, thank you, ma'am. And there's a question in Zoom. Like, I think we have already discussed the answer as well. The use of OCTA and the benefits of OCTA. So we have already discussed about the same, ma'am. Yeah. So thank you, ma'am. So those were the questions for now. Okay. I request the audience to post the questions if you have any while looking at the video in the comment box. We'll get back to you with the answers. Thank you so much.
Do you have any questions? Because she would have some idea after reading so many papers. No, so or any other. Do you have any questions or
any questions, Hema?
Your voice is feeble.
Yeah, Hema, you can ask or you can even mail.
Mail, yeah.
If I get so, I'll mail it to you that much.
Yeah. Sure. Okay.
So I will be making a short announcement, and I'll request Gomadi to share a short video. So we are having our own innovation and research department in Dr. Agarwal's Eye Hospital, and we are let's have the view of the video. Audio is not there.
Yes.
So we have set up this research and innovation department, and people are encouraged to do innovation, and we are working interdisciplinary projects. So we have recently set up this department. So.
Okay.
So we are proud to share this to our audience, and people who are interested in pursuing your further career on research, innovation, and you want to work with engineers, you want to do interdisciplinary research, and it's and Ms. Gomadi will be posting the phone number, the contact number, if you want to know more details about it. So these are the new facilities that we have started. So the students will have the opportunity to explore this. So I'll request everyone to make use of such opportunities. And at this point, I would like to thank Ms. Gomadi and Ms. Meenakshi. So they have done so much hard work in making this happen. So when we see that no student is performing in a certain way, that there's so much of work behind that by her teachers. So very proud of you, Gomudi and Meenakshi. And I'd also
Thank
like
you, ma'am.
so I'd also like to thank our student, Ms. Hema. And Jemima, do you want to say anything?
Thank you, ma'am.
Before we close.
Beautifully covered by both Shruti and Maanasi. Very nice with all the examples and the questions in between as well. So very nice. We would be happy to have more sessions with you, Maanasi.
Thank you, ma'am.
Thank you, ma'am.
I would like to add that the session was very well coordinated by both Ms. Gomati and Ms. Meenakshi. And I would like to thank Ms. Maheshwari ma'am for inviting me. And yeah, I feel like I'm brushing the basics. Thank you so much for this, ma'am.
Thank you.
Thank you so much, ma'am. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
I would like to thank all our audiences because for your continuous support for the optometry series. If you like this video, please do subscribe to our channel and share this video as well, guys. If you have any questions regarding today's session, please post your questions in the comment box. We'll get back to you with the answers. And for knowing about more happenings at Dr. Agarwal's Institute of Optometry, please do follow our Instagram page and Facebook page. With the video, once again, I will complete the session with once again playing the video of the research room. Thank you all for joining. Meet you all next time. Bye-bye.
Thank you. Thank you, Maanasi.
Thank you, ma'am.
Thank you.
Thank you all so much. Meet you all next time. Bye-bye.